Welcome to our webinar number 1 for 2024. And with that, allow me to say Happy New Year. So just a quick introduction of who we are and what we do, especially to our new friends joining us this year. And of course, for those who've been joining us in all our other webinars. So we are the Institute of Economic Affairs, a public policy think tank that is based in Nairobi, Kenya. And our work revolves around carrying out policy research and analysis and using our findings to have conversations and dialogues on and also offer possible policy recommendations. So part of what we do is we use our convening power to have conversations and discussions on different topical issues from revolving around different sectors in the country, regionally and globally, and just try to give perspective and direction in relation to our local context. So before going into why we are here this morning, I would like to thank everyone for being of support to the Institute of Economic Affairs in 2023. We do not take it for granted that you have always created time to join our webinars and to listen in to the conversations we are having and have been following us on Twitter and all our social media pages, and always reaching out to us when need be, to give context, economic context to policy issues in the country. So last year, the IEA was able to carry out 33 webinars, and we do not give ourselves a pat on the back without acknowledging you, our friends and participants, who always created time to join us and just engage with us during those webinars. So kudos to you all, and we hope you will continue to give us the same support this year, 2024. And we are open to having different conversations on different topical issues. So should you have an area that you feel would be of interest and you'd want an economic outlook to it, please feel free to reach out to the Institute of Economic Affairs. And of course, we will be more than glad to engage you and carry the conversations forward. So thank you so much, and karibuni sana. So this morning, we want to have a conversation about universal health coverage and healthcare financing in our country. Why is this conversation important? It is important because we are seeing a lot of a lot of health reforms being discussed and some being passed. And the whole idea is for us to find out, as we are carrying out these reforms, are we actually making progress or making reforms that would accelerate our progress towards the attainment of universal health coverage, or our reforms are pushing us away from attaining universal health coverage? So, and we believe at the Institute of Economic Affairs that healthcare financing is at the core of attaining universal health coverage. Why, we will explain, because we know that universal health coverage is a global health policy goal that aims to ensure that all people have access to essential health services that they need without facing financial hardships. So we are talking about accessibility, affordability, and equity. So any reform that we are carrying out within the health sector would then push us towards the three cores that I've discussed. That's equity, affordability, and accessibility. So this morning, again, why healthcare financing is because if you look at the three pillars under universal health coverage, there is a big link to health financing. So we know that the health sector in Kenya is a devolved function of government, given the 2010 constitution. So the constitution established 47 counties. So that consists of the national government and 47 semi-autonomous county governments. So each of these counties was given, each county is given specific responsibilities, or in general, the counties are given specific responsibilities. And one of the responsibilities that was given to the counties is the health sector. The health sector, having been devolved, then gave an opportunity for the creation of county health departments, county health plans, um, um, health workforce management. And so all these things, when you look at them, has an implication to healthcare financing. And again, when you're looking at healthcare financing, we are in a situation where we are moving from what we were used to, that is the National Health Insurance Fund, to what is now called the Social Health Insurance Fund. So we want to understand what the implication of these reforms means to our attainment of universal health care. That said, when we are speaking about accessibility of health services, you need to know that on average, 26% of Kenyans have some form of insurance. This means that 1 in every 4 Kenyan has a health insurance cover. That's at the national level. When we narrow it down and bring it to rural areas, you realize that only 19% of those in rural areas have access or have some form of health insurance. What does that then mean for our progress towards attaining universal health coverage? Remember, accessibility being one of those cause that universal healthcare advocates for. When we are speaking about affordability, in Kenya, people pay an average of 37,362 for each inpatient visit per year in Kenya. Again, 37,362 shillings for each inpatient visit in Kenya. What does this translate to when we are speaking about that cost per month? It means that for outpatient coverage, on average, each Kenyan spends, who accesses outpatient services, uses 1,735 Kenya shillings, and this is according to the Kenya Demographics Health Survey 2022. So with this given, with this data available, you also have to realize that the majority of people who have access to these services are majorly the older people. For obvious reasons, they're immune as they grow older. Of course, they're more prone to diseases, right? So our conversation today encompasses all this data that we are trying to unpack, and then bringing us back to understand the implication of these healthcare reforms that we are having to the national government and the county governments, and in return, the implication to our attainment of universal health coverage. So with us today to help us unpack and understand our journey towards healthcare financing, we have 2 doctors. We have Dr. Joy Mugambi. Dr. Joy Mugambi is the National Chair for Kenya Association of Family Physicians, and has some expertise when it comes to the devolved health as a devolved function. So when you're speaking about county financing, Dr. Joy is our go-to person, and she's a friend of the IEA and has walked this healthcare journey with us at the IEA. And we are with her is Dr. Davji Atela. Dr. Davji is the National Secretary General KMPDU, and he will be giving us the national perspective and his views on our journey towards healthcare financing and just in general, the reforms that we are having. So that was just to give you an overview of what our conversation is all about. So we are saying it is important that even as we discuss this, we are aware that for us to have health financing we have health financing reforms that are effective, there has to be serious collaboration between the national government and the county governments. Hence the reason why we have Dr. Davji, who will speak to the national level, and then Dr. Joy, who will give us the county perspective. That said, a bit of housekeeping rule, you're all on mute, so that will be as is until our speakers have given their thoughts on our topic this morning, after which we will open to plenary, and my colleague Fiona Okadia will then come in and take us through the plenary, and then we will open up for discussion. So don't mind that you're on mute. If you have any questions as our presenters are making giving their thoughts, please note it down and you'll have an opportunity to ask your questions or give your comments. That said, I'd like to take the opportunity to now welcome Dr. Davji. Dr. Davji, you have 15 to 20 minutes to give us your views on this morning's topic. So once again, karibuni sana.
Thank you so much, Winnie, for the introductions and for organizing this meeting. I also want to thank IEA for thinking that it is quite in order to bring a conversation on the universal healthcare and with the focus on the health financing, because all the components of healthcare and its accessibility actually depends on the financial component of it. As it is, the question from this particular thing is that which way for UHC? I know the word UHC or universal healthcare is not new to us as Kenyans, because the launching that was done on 20th of October 2023 was actually the third one. It means the previous government tried to launch it twice without any success, and this new government has also tried to launch it. The universal health care and the access to care is not only a Kenyan issue. It is an alma mater declaration based on the need to have both the primary healthcare access and also the curative component of healthcare. If we look into our constitution, Article 43, it gives every Kenyan the right to access healthcare and the right to high standard of healthcare, that is the highest quality. That means all of us need to be able to access care to whichever level of facility without being burdened or thoughts of how are we going to pay. That is what is in the Constitution. When we look at the aspect of the UHC, it essentially means that with it, we'll be able to access healthcare without having to go financial hardship. You don't have to sell all your property. You have to use less than 10% of your finances to access the healthcare. That is the drive that the previous government had and the drive that this new government has. But will it be achieved? We know also that the components of health of UHC are not only one-sided. They have to look at aspect of promotive care. That is, the bringing the consciousness of the populations to understand why they need to have this care. They need to go for care when they need it. So that's the promotive aspect of healthcare, sensitizing the community. Then the aspect of preventive healthcare, whereby you have to get the screening of the the population, because when the screening is done, there are a lot of ailments that would easily be prevented in early stages. Then there's this now component of the curative, and then you have the rehabilitative and the palliative healthcare. So basically, all these components then come into the universal health access. That is, it also brings up the aspect of the social aspect of healthcare. That is, to make healthcare not be only a matter of the hospitals and the doctor, but also a matter of within the localities, within the communities, are we able to make sure that the social aspect of it are also considered? That brings the entire framework of the healthcare. As I've said, that in the Article 43 of the Constitution, it is well elaborated that it is our right. But does it mean that if your right, in case you need to access your right, must you have finances for it? Must you be able to pay? Or as you pay taxes, or as you live in a country, is that somebody who needs to be responsible for it? As we know that healthcare, just like education and security, is a social service, which means the government actually need to ensure that the resident or the citizens are able to access the care. That's why it's part of the Constitution. And the Constitution does not limit it to only healthcare and reproductive healthcare. It also brings the aspect of the emergency healthcare treatment. But we are in this country, we know the number of people who go to get emergencies. You get an accident on the road, or you have an ailment that needs urgent treatment. You go to a private facility which is near you based on accessibility, and will you be able to get that care? We have cases that we all know that you go to KUTRH or Kenya University Teaching and Referral Hospital, the deposits that are asked. You go to Nairobi Hospital, you ask for a deposit of 100,000. You go to any other facilities, if you don't have any insurance, the first thing is the deposits. Is that a contravention of the Constitution? We've also seen incidences in the country where you go to the hospital, get care, and then you get detained from that hospital. This is happening both in the public facilities, because we have cases that has been reported in Kenyatta National Hospital. We have cases to the point that people had to go to court in Nairobi Women Hospital. So are these contraventions of the constitutions? Are these ensuring that we have our right of access to care are being abused by these hospitals or by the government? So this forms the basis that then how different is the government going to make sure that the right to access to care, the universal healthcare access, is actually implemented. And also we must really be cognizant on this, that yes, as much as health is devolved, as Winnie said, health is a shared function. We have level 6 across the country that are fully managed by national government. Then we have the level 5s to level 1s, level 4s, 3s, 2s, and 1s that are managed by the county government. So what are the points of referrals? What are the points of gaps that exist between the county referral hospitals and the national referral hospital, to the point that the elements that we expect to be treated in level 2, 3, 4 are not done, to the point that they're all, we have a lot of people going to Kenyatta National Hospital or to KUTRH or to MTRH. These are the components that we have to look into when we are discussing the universality of access to care. As we all know, that the aspects of universal healthcare is also anchored in the Vision 2030, which I must emphasize, it's not just healthcare for the poor or poor health or private healthcare for the poor. It is accessibility to the highest standard of healthcare. It's the Vision 2030 is part of the SDG 3, which also brings about the aspect of the universality of access to care. And therefore, this is a very important thing that we have to look into, that if we have to look to access the care as a country, what then the government should do? What mechanisms should government ensure that every Kenyan has access to care? I know, and I think it has been, we've all seen that there is always a recurrent launch of the UHC as it is in the country. But have we been doing it based on the statistics of the disease burden in the country? Have we been looking at it that what is the out-of-pocket expenditures of the Kenyans? Because healthcare can never be free. When healthcare is being provided, there are two prospects of it. Either there is government funding this particular healthcare in terms of tax, either there is insurance component of it that is being provided, or the out-of-pocket expenditure. When we look at it, and as it has been explained, in the country, in Kenya as of now, we only have 26% of Kenyans that have insurance-based. For a long time, there has been the budget that Kenya has been putting on healthcare is less than what was given as a budget declaration. The highest that it was in 2021, 2022, which was 7%. The budget of 2023, 2022, 2023 is actually at 3.7%. It's actually gone even down. So with that, are we able to access the healthcare? When you look also the new government that we have now, the budget of universal healthcare component of the health budget is at 18 billion. The previous government had put 62 billion on universal healthcare. So is the government having a plan of universal healthcare through launching and expecting to collect the funds, or is the government already having a plan that will ensure that there's access to care? Those are the questions we need to ask, because we saw it in the failed launch of UHC in 2022. The budget was higher, up to 62 billion. But the current one has a budget of 18 billion, and then we have a lot of bills that have been put in place. So the question to ask is that, are the bills meant to collect money for the UHC? So generally, before we really go down into this aspect of health financing, I will try to bring out the critical components of which make sure that actually the healthcare is accessible. Because health is a right. Universal healthcare means that you go to the nearest facility and access the care. You don't need to worry about your socioeconomic status. We know, and it is based on the census report of the country, that there's one critical component of healthcare that is human resource, that is the health workforce. Across the country, we have a human resource density of health workforce of 15 against a recommendation of 45. So it means that we actually lower in terms of our human resource component. The number of doctors, for example, in the country, we have at a ratio of 1 to 17,000. Yet the WHO recommendation is 1 to 1,000. So there's a high possibility that you will visit many of the public facilities. I mean, the InfoTrack report indicated that 72% of Kenyans will first visit a public facility. But you go to the hospital, the waiting time is longer than expected. Mostly it's because there are no health workforce employed in those facilities. There are no doctors employed in those facilities. There are no nurses employed in those facilities. There are no clinical officers. So you end up staying for still a longer period before you get care. So the alternative of many of the Kenyans will be going to the private facility. But then the situation is, if you're going to the public facility and then you find yourself ending up in the private facility, the cost of care will actually change. So that's a very important thing that we must look at. That is there commensurate employment of health workforce to ensure access to care. The other thing we must look at is that the shortage across the country has made the National Referral Hospital to be congested by many of the patients across different parts. So the aspect of human resource cannot be ignored when you're talking about the universal health care. And that's why we keep on bringing out the need for the government to actually plan and budget on ways to ensure that the hospitals are efficiently having enough health workforce to offer those services. That's a very critical component. And this cuts across the mixed skills of all health workforce. And ideally, this is also what will ensure that there's high screening of patients within those within level 1, level 2s, level 3s. So health workforce is a very important component of the universal health care, which we have deliberately ignored as a country because the employment of health workforce for the last 6 years has been only 10% of the number that we need. The second component is the health products. Basically, if you visit any hospital or any clinics, you really need to get medications. But what plans have been put in place? We have, as we speak today, the county governments, the 47 of them, holds KEMSA 3 billion. It then means that if you go to these hospitals, if you are sick, you'll realize that you will be treated. If you find the doctors, you'll go to the lab. If you find that the reagents in that lab, and in most cases, you'll be sent outside the labs, then from that point, you'll be going to the pharmacy, and most you'll get the out of stock in the drugs. That alone is an impediment to universal access to care, which then it is very important that there has to be a logical plan on payments of the commodities or drugs or the health products from the suppliers. So which forms a very key component in the healthcare delivery. The other issue is the aspect of leadership and governance within these particular institutions. We know very well that there's a lot of employee migrations or worker migrations that leave and high turnover of workers, both in the county government and in the private facilities. This always occurs because of the poor management, poor leadership in those particular facilities. So what incentives, what motivations leads to increased number of health workforce in those facilities is a very important component that has to be considered. But all this actually goes into what we call health financing. And what then it will make us see a better approach to this health financing. There are always three ways. Health care can never be free. It can either be paid by the government or the individual takes care of his own health care. As a country, or as a way of doing it, there are only three models. The first is out of pocket. And as a country, we spend 150 billion annually in out of pocket expenditures. And this is attributed to dysfunctional public health care that exists in the country, and also the high rise number of private facilities and then people do not have the insurances. The second aspect is to having insurance, the pooled insurance, like we had we had NHIF. So through NHIF, the 26%, and those who have the private insurance, then they're covered. The other aspect is the tax-based, where the government takes the role of purchasing the health care for the population. So those are the three approaches that have to be undertaken to ensure there's access to care. But for that to happen, we have to have mechanisms that ensure that there's access. That's why we talk about, that's why we see that there are bills have been brought forth to enhance healthcare access. The three bills that have been brought, one of them is Facility Improvement Fund, which as a union, we've been really saying that it's quite a noble bill. Why are we saying so? That the act will ensure that the funds that are collected in a facility are ring-fenced in that facility to ensure that you have drugs, to ensure that you have reagents, to ensure that services are being offered. So that's the one bill that we all believe is good for this particular healthcare. The other bill that has been put up is the National Hospital, the Social Health Insurance Fund. It's a bill that is having two-pronged way. On one side, it has increased, we'll say, the collection or the deduction of workers and for Kenyans into that particular insurance base. And then it has also a component of tax that is on part of the primary healthcare fund, the chronic and chronic emergency and critical healthcare fund. So what we'll say about social health insurance fund is that, yes, as much as it brings these other two critical components that are very good, it's more geared towards a private sector. It's more aligned towards the private sector. And why are we saying this? Because we have level 1, 2, 3s in the rural areas that are dysfunctional. They have one nurse and some don't have any nurses. Then we have the private facilities within the cities. So it means that it's only those who will be going to the private facilities that will access care. But in essence, we know that a bigger component of healthcare is devolved. So essentially, the funds should have been used to ensure that there's a functional level 1 to 3 within the counties. So that's one of the concerns that are there. Number two, we have this aspect of the comprehensive medical cover, which was being provided to the civil servants. It's being provided to the edu-afia for the school-going children. It was being provided to the retirees. The major component of this edu-afia is that it was giving all these, about 6 million Kenyans, access to care indefinitely in any facility. And therefore, it will be more prudent that the healthcare of SHIF or the package of SHIF was made more comprehensive rather than reduced. Why am I saying reduced? It's reduced because in the regulation, they brought the aspect of copayment. So it's only those who had the comprehensive cover that were able to access all the level of facilities, be it a faith-based, be it public, be it a private facility. But now with the Social Health Insurance Fund, it has brought another component of it, which we now call when you go to access care, there's a baseline. So within this baseline of care, you go to the hospital, and if, for example, you're having a service which is, let's say, it's a cesarean section, and the cost of it is 30,000, the cost of it is 100,000, the Social Health Insurance Fund will only pay the 30%. Then you, as an individual, whether you are a private, whether you're a private employee or a citizen, or whatever person you are, you have to pay the remaining amount, meaning the cost of care will be left to the hands of the provider without the social health insurance actually giving an input. But essentially, to increase access to care, once somebody has an insurance, ideally the costing for services should be done such that once you have that card, you just go to the facility and access care. So that is the part that we were looking at and seeing that it will be more of an impediment to access to care. As I finalize, I must bring up the proposal that we have as a union that we know will actually make this idea of UHC functional. It's not just an issue of brick and mortar, building hospitals that are level 5, level 7, or 7-star hospitals. There's actually need to have functionality in those facilities. There has to be human resource component in those hospitals. There has to be reagents that will make equipment that will make those hospitals work. So that's why we're saying it has to be looked at holistically in all the components. And for that to happen, we must see to it that the budget of 2023-2024 was only at 3.7%. Yet Kenya is a signatory to Abuja Declaration that agreed to allocate 15% of the budget to healthcare. So that actually makes us understand why there's a bigger out-of-pocket expenditures in the country, because our allocation, our budget to healthcare is quite low. We are still hoping to collect more funds from probably the Social Health Insurance Fund. So that's why I think there's quite need for the government to actually inject more money and budget for the healthcare. The other thing that is quite important is the aspect of the tax-based. And this, yes, it is there currently in the Social Health Insurance Fund, both in the primary healthcare and in the chronic, critical, and emergency care. There's actual need to have Kenyans accessible to this fund, Because when there is something that has been put that you must exhaust or deplete your social health insurance fund before you actually access the chronic fund, we keep on asking, how do you exhaust a pool of insurance that is for all the Kenyans? That's why this particular fragmentation of this fund will not actually bring value the way it's supposed to bring, because ideally we have Kenyans currently who have the chronic conditions, those who have cancers, those who have diabetes, those who have renal conditions. They actually should be assigned so that they have access to these chronic funds without really worrying on the existence of the social fund or the primary fund. The other thing that we are putting out very closely, that the ring-fencing of funds. We have seen situations whereby there's facilities within the counties who are offering services, and then all this money is pulled into the county budget. The money will be used by governors or by counties into other activities, and then when the Kenyans or when residents go to the hospital, they don't get the drugs. So there's need to actually reinforce these particular funds to ensure that there's continued service provision within the facilities. The other critical component that has failed across the country, and this has been demonstrated by the number of strikes that we keep on seeing in the counties, is the aspect of the human resource. We have realized that for health workforce to be standardized, for us to have continuous employment of health workforce, the way we do with security, the way we do with the police, which will ensure access to care, then we have to change the model from the traditional way of having the counties just employ as they wish, which they failed to employ, to the model of the Health Service Commission, whereby the government will budget from the exchequer and employ annually. And this has also been attributed to the Public Finance Management Act, which has a ceiling of 35% for all the counties. That's the money that is meant for the emolument and for the wages. But as we know currently, out of the 47 counties, about 43 of them have already exceeded the 35% mark. Some are actually at 50. So it then means that the shortage in the facilities across the country will remain unless that ceiling is either changed, or unless the money that is being allocated to counties, which we saw in the last budget was only 10%, is doubled. That's the only time that we'll see now there's a change in the functionality of the county facilities. Then lastly, I think we also must strongly invest in the local manufacturing of the products, because we depend a lot in importing a lot of the medicines, the essential drugs, and with the depreciation in our currency currently, it means the cost of medicine, the cost of drugs have also skyrocketed. So there's actual need to also have improve or increase on our local manufacturing. Lastly, I think I've said this, we have to look into the matter of annual recruitment of health workforce the way we do with the teachers, with education, and with security, because all the social functions, and they must be provided by the government in the best way. They should not be privatized the way we are seeing them being done now, to the point that it's only those who have, or those who have ability to get to pay can access the care. Thank you.
So yeah, thank you so much, Dr. Davji, for giving us a perspective towards universal health coverage, and also just unpacking to us where we are as a country as far as attaining universal health coverage is concerned. And of interest is that we keep saying that a healthy nation is a wealthy nation, but are we really making it practical by putting together the resources that are necessary to get us healthy and wealthy? And then just looking at your presentation and your indication of the health financing challenges. If you look at the health financing challenges that we are having against the universal health coverage pillars the universal health financing pillars that we have, you notice that health financing, human resource, health products and technologies, health information systems, all these challenges put together are very strongly related to our budget priorities when it comes to the health sector. That said, we are in agreement that our health budgeting is still way on the lower side, because according to Kenya Economic Survey in 2022-23, we only allocated 4%. Budget allocation to the health sector was 4% of the total budget. And I mean, just going to their budget declaration agreement, it's supposed to be at 15%. So given that and if you look at it conclusively, you notice that there are still a lot of discrepancies and a lot of challenges that are hindering us from attaining universal health coverage. And for us, we believe that at the core of those challenges, it is the issue of health financing. So we might have proper policies, we might have proper health infrastructure, but for as long as our budgets towards the health sector is low, we will still have a challenge in attaining universal health coverage and meeting the threshold for for health financing within the country. So that was just to give us a perspective for what is happening at the national level. So we want to now proceed and just get a feel of the implication of our inability to do a proper health financing. What is the implication of that at the county level? So just in general, being devolved and with everything going on, where are we as far as the counties are concerned? Are they able, do they have the financial capacity to perform their mandate as healthcare workers at the county levels with financing? And maybe we are speculating, probably Dr. Joy will tell us, guys, hold, we actually have that financing. So let's just hear what Dr. Joy has to say as far as health financing at the county level is concerned. Then we can make a decision for ourselves, given her presentation, where we are with health financing at the county level. So Dr. Joy, karibu sana, you have 15 to 20 minutes. Thank you so much.
Thank you very much, Winnie. Allow me to prepare my presentation. I'm Dr. Joy Mugambi. I am the National Chair for the Family Physicians in Kenya, and I'm honored to be back here for the IEA presentation, talking about challenges, barriers in implementing effective financing for UHC in Kenya. I'm a policymaker as well as a healthcare leader, being a policymaker within a county and working around health financing, administration and planning. And yes, we do have a number of challenges being faced. I thank the previous speaker, my colleague, Dr. Davji, for opening this session with a bang and being able to share the perspectives from the union side. He has quite articulated about UHC and what it entails. Basically, we want to look at equity, equality, and finance risk protection of the general population. No one should seek healthcare and face financial hardships. How does a government assist the population to ensure that it is healthy and it is not facing any hardship? Primary healthcare is the roadmap. I am a primary healthcare provider, and primary healthcare is essential healthcare made universally accessible to the individual and acceptable to them through full participation. We've seen public participation forums, memoranda being sent out for the policies that are developed, and ideas and ways in which to improve primary health care being sought from the public. It should also be at a cost that the community and the country can afford, and that it involves the individuals, the households, and the community as a core to the primary health care. So there has been a lot of work on the ground since 2005, as much as we've had the Astana Declaration, the Alma Ata Declaration before the Astana, but now we are on a journey towards strengthening primary health care, and latest of them all is the 4 UHC Acts, as well as implementation of a strong community health strategy to ensure that at least each household has access to someone with some health knowledge who's able to assist them, guide them, and refer them appropriately and timely so that they get their preventive and promotive advisories and prevent diseases from escalating to severe illnesses that require advanced care, which is very costly to the government and also very costly to the county. So let me start with challenges. In Africa, we say don't start with bad news, start with the good one, then end with the bad one. But I think it's usually nice to also talk about where we have incurred challenges as we implement UHC. It's nothing new. We've had the implementation ongoing, as articulated by my colleague. There has been inadequate government budgetary resources. We've had that from DAFG. We've not attained the 15% as required by Astana, the Alma Ata Declaration many years back. We are now into the Astana Declaration. How do we ensure that counties are well resourced? They have adequate budgetary allocations, and the Department of Health has enough to be able to function, because health is a public good. Health is never planned for sometimes. Yes, you can plan for prevention and promotion, but you may not be able to plan for emergencies. Let's come to weak health systems. Why are we all rushing into strengthening primary health care? We've done a lot to strengthen secondary health care. By the time someone is being attended in a secondary healthcare facility, that's the level 5 and level 6, all the way from level 4 to level 6, then you have had a long duration of illness and lack of care for a long time. By the time you're getting to the stage of advanced cancers, the stage of advanced diabetes with complication, the stage of hypertension with strokes, these things could have been managed at the very primary healthcare level at the dispensary that's right across your home state. How do we ensure that that facility is functioning top-notch? For a long while, this system has been donor funded. This system has not been financed by government, and this is why we are looking towards ensuring primary healthcare is funded, that it is stronger, and that it is functioning. There is high poverty levels. How do we ensure communities can resource themselves in terms of their healthcare provision? How do we ensure those vulnerable, the poor people, can be reached by health services? And how do we ensure that they also can be served like someone else who's attending a health service in Aga Khan? Then selecting the right package for benefits and timely reimbursements, because we have seen most of our challenges as counties and as health facilities at the lower levels. Our biggest challenge is timely reimbursements. How are these packages selected? Do they serve the public or do they just serve the privates? And I hope that with she coming in, we'll have an equitable distribution of revenue and ensure that the packages are in favor of that vulnerable person who cannot afford and cannot be able to go to the high-end facilities. Then integration of the informal sector. Informal sector also makes its money, while the formal sector is quite suppressed in terms of the revenue generation. How about the informal sector? What contribution do they have? Health is being financed adequately, and that's care that they would need. We need better accountability framework. Yes, we have public finance management framework, but in healthcare, sometimes health is an agent. Yes, within those public finance management framework, money needs to be accounted for, and we need availability of goods. We've heard from my colleague in terms of pharmaceutical product and the reimbursements that we do and payment and pending bills. We need local manufacturers. We have diseases that medicines are not available locally, and when they are not being availed from other countries, we have challenges. When costs go up, you have got no competition to get these drugs from other areas. Even globally, we need access to the patents that are available of medicines to be able to avail locally available cheaper drugs for our people to be able to get care that they need within the country. So how do we cap these challenges? One is enhance efficiency in revenue collection. Revenue seeps out, and where a tank has holes, it needs to be sealed or procure a new tank. And these revenue collection loopholes are one of the key challenges that we face as counties within our facilities. But we are trying to mitigate that by ensuring seamless cashless mechanisms of collecting funds. We also need increased health budgetary allocation. There are a number of activities that really cost the departments, and this is especially medication. When you visit a facility, you're looking to have a package of drugs go along with your consultation, or a service delivered to you, be it surgery, be it a small procedure. And if the medicine and products that go with that are not available, then it is difficult. And that goes with a budget allocation. So an increase in that would really curb the challenges for implementation. We also need to initiate schemes for informal sector vulnerable persons. We've seen the indigent scheme, which was a bit skewed and really needed improved mechanisms of ensuring reimbursements are done, and even selection of those vulnerable persons. Why not select to be frontline workers at the front? They cannot select who they see, and they would not run away from diseases. How do we ensure that we also protect them? We ensure that they also get healthcare in a timely manner so that they are available to provide health services. And these are things that we need to ensure that we curb as we ensure that we are implementing UHC. Then broaden quality health coverage through reforms for the whole country. We are now reforming the primary healthcare, which is music to our ears as primary healthcare providers. And we're also doing health financing reforms. The Facility Improvement Fund has been one of the key strengths that the county I work in, which is Nakuru County, has had for years, for the 10 years of devolution. The retention of funds within facility and utilization as an appropriation in aid has made services more efficient, faster, and it is easier to tell even a good manager who can as well manage their resources in a timely manner. Then recruit and retain. Health workforce is a key investment in any county. And where you can recruit and retain good quality healthcare providers, then we'll be able to provide universal health for our people, which is equitable, of quality, and well-resourced, because the human resource you have is the same that will generate revenue for you. There are acts that support. I won't belabor onto them because my colleague has very articulately discussed them. Mine is the key act that I look upon is the Primary Healthcare Act and how we are implementing it, because with a strong primary healthcare, universal healthcare will be achievable in our country. So our three paradigm shifts to address in primary healthcare is moving from a curative approach to a preventive approach, moving from haphazard assignment of facility to a defined community approach where we are having community health mapping, and being able to identify even the conditions in those households, so that as we plan our budgets, we are planning knowing the population in Nakuru, majority have this condition and they need to be budgeted for. We need to invest on antihypertensives because probably we have this number. We need to invest on antidiabetics because we have this number. So a key role will be played by the community health promoters as they define our community. We also need to move from fragmented primary healthcare structures, that's the level 1 and 2, and utilize a primary healthcare that is strengthened services in terms of primary healthcare delivery, that we know each household, their needs, and addressing those needs at the very household level. So in terms of the primary healthcare network, the spokes, the hubs, we've worked for a very long time seated in our hub as doctors, not knowing what happens at the very peripheral level and not reaching the people. Sometimes our people really, really want to get to a specialist. Distance hinders them. So moving 100 people, level 4 facility to congest it is harder than moving a specialist down to the people and linking them to the household, ensuring they are linked to the level 3 and 4, and ensuring that multidisciplinary team is functioning, and we change the way our business operates for efficiency so that we are able to reach the people, bringing the specialists closer to the people rather than the people to the facility where they congest and make work harder. So we want to take health to the house. This is what we do. Imagine that gentleman at the quarry, if he was to take even a minute away from his casual task, he wouldn't get paid for the day. And he would spend his time at the healthcare facility, just as we have been told the healthcare facilities are congested, time is wasted. But for universal health to work, we have to change the way we run our business and bring it closer to the people and ensure that the households are catered for. This old lady might require you to leave your job and come take her to hospital. So that means a young person will be off duty, an older person will be seated in a waiting bay where they may collect a communicable disease and they had only come for an uncommunicable disease, maybe hypertension, diabetes, but go home with TB or pneumonia, and they will end up in hospital again and cost the investment, the department more and the country more. So let's change the way we do work. Thank you.
Thank you so much, Dr. Joe, for your presentation and just giving us a perspective into your thoughts on social health insurance fund, and of course, just your general views as well on healthcare financing. In your definition of primary healthcare, the one thing that I picked was full public participation. The key word to underline is full. So to what extent, and probably it's as we transition into the plenary session, the one thing that we would want to understand is to what extent do we involve the public in public participation when carrying out reforms? Do we say we have conducted public participation as a formality and to take the boxes of requirements for bills and for all those things that we need? So do we do it as a formality, or is it something that we actually do with bearing in mind that we actually need the public to understand and engage in these reforms, so that we're not having the public raising questions? And I think a lot of these questions that the public raises comes about because of the lack of full public participation. So we come up with policies as a country, and then the public is sort of pushed into this public participation without really understanding what the reform is about. And I think that's the whole point for having public participation. And then you also spoke about misuse of resources. I mean, as a country, if we go through the Auditor General's report, we should, for lack of a better word, get some beatings, because the level of misuse that is reported by the Auditor General is actually embarrassing for us as a country. That said, looking at the health sector relating to misuse of funds, the IEA, through its public finance management program, conducted an analysis to assess the value for, conducted a value for assessment on the managed equipment services project or program that the government had, and just to evaluate the progress that had been made within that project. And I mean, the findings were actually really, really scary, for lack of a better word again, because the level of misuse, when you're speaking of no value for money, when you're looking at the underutilization of the equipments that were delivered, was really, really shocking. And this was, the study was done 4 years into that program. So that tells you that within the 4 years, a lot had gone on, and people sat back and watched as that whole project came crumbling. So back to our conversation of healthcare financing, we will be having this conversation, but pegged to these issues that our two presenters have raised very, very clearly. But another thing as we speak, and I mean, we will be discussing SHIF because, sorry, it has been passed and the deductions are going to be done. It is a bit more focused to preventive. But as we are focusing on preventive, let us not forget the curative. So let us not focus on implementing the preventive aspect of the policy and forget the curative. And the curative for me is where a lot will be going on. And I mean, I would like to hear your views on that as well. So probably as I hand over to Fiona, it would be interesting to hear preventive versus curative. What is the balance under SHIFT? So that said, I'd like to now take this and hand over to my colleague Fiona so that she can take us through the plenary. So Fiona, karibu sana.
Thank you so much, Rini. And thank you so much to our presenters and the participants. So this is a plenary session where if you have any questions directed to any of the participants, you can be able to either raise your hand and then ask it orally, or you can type it in the chat box and I will read it out to them. But even as we begin, I had a question myself, just listening to the aspect where we want to increase the total budget allocation to 15%. And I got curious in terms of, should the focus be so much on the percentage or in terms of the absolute number? In this sense, if today, for example, we decide that the national budget will be 2 trillion, yeah, 50, and then we take 15% of that, and they decide to actually allocate the 15%. So would 15% of 2 trillion, for example, would it be enough to care for our health needs, or should the focus be in terms of, we think as KMPDU, or we think as, all these professional bodies, that, we need about, say, 100 billion to be able to provide UHC, so that then whatever the percentage is, we know that this is enough to hire the doctors, hire the nurses, build the hospitals, equip the hospitals, all that. So I'm just curious in terms of, when we're advocating, should the focus be more on this is the total amount or the percentage? Yeah, that was one of the questions that I had, but I can see from the chats that there's no questions. So in case there's anyone who'd like to ask their questions orally, I can pick you at this point. Okay, there's Dr. Joy. Can go ahead.
Yeah, probably as we await other questions, mine is this: when it comes to the 15%, it might have been the most logic in 1968 during the Alma Ata Declaration. But looking at economic changes, the population growth, I think forecasting and really looking at our monitoring and evaluation report would give us a better absolute number rather than a percentage of the budget. And this is something I've seen even as we prepare our own budget. Yes, you can say give a certain department 30%, give another one 15%. But there is the needs on the ground. When you do a pharmacy products quantification and you forecast how much you need per month, it cannot total to the 15%. Definitely, it's an absolute number, which could be more based on the total population. And then remember, there are areas and counties which could have less populations, but bigger demand in terms of their health needs. Then include pandemics, emergencies, disasters. And when those are included, even that 15% may not be enough. So we need to look for a more savvy way of calculating our needs rather than just the 15% that was articulated many years back.
Thank you. Thank you for that.
Yes, to weigh in on that, I would say that ideally, the only way you can say you prioritize healthcare is if it forms a critical part of your budget. And if you see the way it is, that the current budget of healthcare in relations to the national budget are 3.7%. And then it directly explains why we have a dysfunctional public healthcare. and why then the out-of-pocket expenditure has skyrocketed. And then that also results into the aspect of health being a financial burden to many families. So putting budgets into the healthcare then as a component, and that's the information from Abuja Declaration. That is, when you have 15% of it as part of the budget, then it's going to ensure the critical component that my colleague Dr. Joy has mentioned, and that I've mentioned, in terms of the human resource, in terms of the infrastructure, in terms of the medicines, the essential drugs are available. They have to be bought. But when we do not consider it as such, then we have to continue seeking healthcare on the other side by out-of-pocket expenditure. That's why I think it is and that's why there's a commitment. And if you see the countries that have actually done that, for example, in South Africa, before they went into 15% of their budget into healthcare, essentially they tried to privatize the entire healthcare, and then it was not working. That's when now they realize that they need to actually budget for healthcare and make it work. So it is very critical thing. In our country as of now, the out-of-pocket expenditure is about 150 billion. If we have, let's say, 300 billion into healthcare, it means that most of the families will be actually cushioned. And again, you can also see on the WHO recommendation in 1981, talked about 5% of the GDP, which is actually more implemented in most of the Western countries, most of the developed countries. So health can't be free. There has to be a deliberate priority to budget for it to be accessible. And we can actually see to it, and if it's comparatively done, countries like Australia, the UK, all these Western countries, there is a deliberate higher budget in healthcare for us to actually have access to it. There's also one thing I must say: the moment we start looking at health, we look at healthcare as an expenditure, then we keep on looking at how to reduce that budget. But essentially, when we start looking at healthcare as an investment in the country, because we need healthy individuals to build the economy, then it means there's a more priority. And that was the call that WHO was doing to almost different countries during COVID-19 and even now. But we must look at healthcare as an investment and put it as part of the budget for investment on the people. Thank you.
Thank you so much, Dr. Dagji, for that. I can see that there are no questions, so probably you can address Winnie's concerns as we wait for more questions.
I want to bring out this issue of the preventive and curative from the presentation of my sister colleague. There's a bigger alignment of the government onto the preventive more than on the curative aspect of it. So, and yet we see from the census that was done recently that about 7% of the facilities across the country are the only ones where individuals can work and get the services. So there should not be a aligning of the government so much into the aspect of the preventive and promotive without actually engaging skilled professionals to actually provide care. So there needs to be an actual balance, because at this point we have not reached, I will say, even 30% of curative access to care. So if we ignore it and then move on just one side, then you're going to have an imbalanced system, whereby, yes, they will be promotive. They'll be mopping off the people within the communities to go to the level 3, level 4 facilities. But who will take care of them in those facilities? Where will they get the care that they need? So there has to be a balance that the government has to put for the universality access to care. Thank you.
Thank you. Okay, I can see a hand up from Frederick Ogilo. Frederick, you can go ahead.
Yes, my main concern is, like, as in NHIF, a majority of the contributors were paying so much and they were not getting value for money. Those who are actually benefiting were the civil servants. Now we've been moved to this elephant known as UHC. Will we benefit as much as what the civil servants were getting, or will still be at the same state, contributing so much, our income being eroded and still getting nothing?
Okay. I've noted your question.
Hi, Frederick. Thank you very much for your question. Well, one thing we know is the social health insurance is coming in to bring in equity. And yes, the health worker civil servants package, or the civil servants package, will be no longer available. But these are discussions that are still being held at various levels. And I hope that part of the protection of the health worker is one key agenda in any county government and any government. Thank you. Back to my colleague, Dr. Damji.
Yes, I just want to add that.
Excuse me, you did not answer my question.
I want to answer you. You are saying that as per the NHIF, the more beneficiaries were civil servants as compared to the public, and therefore you are wondering whether the Social Health Insurance Fund would improve the discrimination that was in existence, or whether now the public will have better access to care. And I think that brings us to the issue that we've been really discussing as a union with the government. And it also, NHIF Amendment Act of 2022 was trying to cure something that had been in existence before, where you go to the hospital and you only get a report of bed and other services you have to top up or you cannot get them. And then what was being brought was that once you have an NHIF as a super cover, when you go to any hospitals, you get the cover, the same way the civil servants were getting. But I must explain to you that the civil servants were getting the comprehensive cover because they relinquished their medical allowance of 5,000 into payment to the NHIF. So as they were paying 1,700 just like everybody else, they were paying an extra of 5,000 per month to make them have that comprehensive cover. So essentially it was an enhanced cover package that they were having. So most of the time, I think many people don't know that particular part, that they relinquish the medical allowance to get this particular cover. So Social Health Insurance Fund is saying that it's bringing equity. And that's why you realize most of the unions were calling for refund to that particular medical allowance that they relinquished, so that they can also, so that they don't get paid to be charged double. There is one thing, though, that is of concern to us in the union, and I think everybody should be of concern to, that as much as we are saying we have the social to be your employer, or if you wish, you can have an extra private insurance, because the Social Health Insurance Fund will only give a baseline. And I gave an example when I was presenting that, for example, if you go and you're doing, for example, a cesarean section, which is a surgery or a procedure, which is 100,000, then Social Health Insurance Fund will only cover maybe 30,000. Then the other 70,000 you have to pay out of pocket, or you have to get another private insurance that pays it. That's the concern you are having, because you're saying, given that we have increased contribution, it is important that once you have that card, the way it was in the amendment of 2022, it is now the responsibility of SHIFT to negotiate with all the providers, do the costings, so that you is just to present the card, you have the SHIFT and get the care. And that's what you're proposing in the regulation. I think it's what all of us need to propose, so that you don't have a jeopardy of contributing over 10,000, 15,000, and again, you have to get a private insurance or do an out-of-pocket payment. Thank you.
Thank you so much. I hope that answers your question, Frederick.
It is well answered.
Okay, that's great.
Thank you very much. I've just stepped into the SG's officer. So I have just one comment to make, especially to my colleague, Dr. Joy Mugambi. The whole idea, there's this idea that has been propagated over time that prevention is better than cure, preventive medicine cheaper than curative. And this narrative is being bandied around by government and its functionaries in their attempt to avoid their responsibilities around curative healthcare. Dr. Joy said that we have invested heavily in curative services. What do you have to show for it? What have we invested? Our hospitals still have poor infrastructure, no drugs, no workers, no equipment. Yeah? We are just engaging in what we call a game of musical chairs. That all of a sudden, you dropped the curative services, now coming to preventive. How is preventive cheaper when you tell that woman to use safe, clean drinking water and there's no piped water in this country? How do you say that preventive is cheaper when you tell that woman to take a balanced diet and they're sleeping hungry? Not even a single meal a day. You can't feed them. How do you tell that person that preventive is better than cure when the vaccines for life-saving vaccines, like in case of sickle cell patients and cervical cancers and all that, are not available widely? Yeah. So in the long term, the only way preventive becomes better than cure is when you live in a country, a developed country, where every house has running tapped water, everybody at least has 3 meals of decent balanced meal a day, then you can say preventive is better than cure. But in our country, in our setup currently, preventing cannot be cheaper than cure, because that child who's coming because of malnutrition, they don't go there because the mother chose not to give them proteins. They lack that. That person, that cholera outbreak, is not because people don't know they need to wash their hands. There's no running water. So until that, to stop unnecessary deaths, we have to invest heavily, I repeat again, in curative medicine for now. So that even as we then come from that aspect of curative medicine, we also improve the socioeconomic status of the communities. Because we also know that most of these illnesses that kill people, the infectious diseases, come from amongst the poor people in the slum and informal settlements. Yeah. So until Kenya attains that point that none of us can sleep hungry or lack water to drink, we must never drop the responsibilities of us paying for the curative services. Number two is also not an issue of either or. That all of a sudden we are being told we have stopped curative, now we're investing in preventive. No. We have to do balance as we drop the curative and bring up the preventive. We have to until reach an equilibrium, then we tilt it, but not just dropping it off. But of now, and this is my biggest problem with the shift and these primary healthcare stories, that somebody promised to hire 20,000 healthcare workers, then he goes and hires 100,000 villagers who has no idea on medicine. You give them kits to BP machines and sugar testing machines, that even the dispensary, where once they've tested the villager and sent them to the health center, in the health center, they don't have the machines. So why have we sent them there? You've sent them there, there's no doctor to him to receive them and to interpret whatever was found by that villager working around those kits. You get that? So we have to somehow, as a country, ask ourselves that how do we, is it that we're just going to talk about healthcare because we want to change the indicators? Because with all these flowery languages, the indicators of healthcare in Kenya is still getting poor. Mortality rates amongst mothers and children is still getting higher. As I will tell you how devolution is working. The numbers are not showing the true picture of a country that knows what it's doing. As I finish, the issue around the financing, we have to decide as a country, which model do you want to go? Do you want to go the tax-based way or the insurance way? But I know for sure that because of the high number of people in the informal settlements, the 80% of informal sector workers, you are not going to survive. Ghana tried and failed. You're not going to survive by the tax base or the insurance, sorry, by the insurance base. Because how will you force them to contribute? How will you force them to pay? Most of them only pay when they fall sick. The adverse selection component. You break your leg, then you pay NHIF. Even if you need to pay for 12 months, it's just 6,000 shillings. Yeah. And you say that you're going to get mean testing of how to know how much they're going to be paying. So what about if you mean test me to have a motorcycle? Tomorrow, Mogo or whatever withdraws their motorcycle and I become now motorcyclist. Will you come and test me again? As an individual, I believe that the best way of handling healthcare financing is to make sure that 1%, 2% of what we tax Kenyans is secured on healthcare. So that every time ukilipa ushuru, a part of it goes into healthcare. Then use that to improve the healthcare of our people. And on a closing remark, that we also have to decide as a country whether we want to strengthen public health systems or we want to collapse them and let profiteers run with it. Because as long as private profiteers are in this space and we encourage them, I'm seeing the current government encouraging them, we're in for a long ride. Why? Because the businessman only comes to healthcare for profits. Yet as a social function, health must be a loss-making venture every single day. The moment health starts making profits, we have a problem. And that's where we're headed to. Shift is just a renamed NHF given to private sector. Right now, you hear about this new farmhead tender for 30 million euros of strengthening dispensaries and health centers with equipment. It's purely on the entrepreneurship. MES did nothing, just bought machines, people ate money and left. So we have to decide as a country, repeat again, do we want to privatize healthcare for profit, or do we want to strengthen our public health systems? You hear about the primary healthcare fund that people are talking about. When you put Nyabola dispensary in my village where I come from to compete with the AR, both of them are level 3s, or level 4s, or level 2s. Of course, Kenyans will always go to private hospitals. So if there's a fund, a taxpayer fund secured to be claimed, the private sector will be claiming it more than the public sector. It's obvious. Kenyans will rather go to private for obvious reasons. You get that? So our position as a union will still say that the taxpayer fund, you cannot tax public money and take it to private hands. Use that taxpayer fund, the primary healthcare fund, and the other emergency and the chronic illness fund to improve public facilities, to improve those clinics, to avail drugs, to employ people that Kenyans can then choose to go to the public hospitals. We must ask ourselves, why are Kenyans moving from public hospitals to private? And they're not very good private. They're private for poor, where there's one doctor or one clinical officer who is everything. He's a lab guy, he's a pharmacist, he's the jack of all trades. Thank you.
Thank you so much, Dr. Miskela. I'll go to John, and then in case Dr. Joy has anything to add on that, she can do so as. So John asked, how many counties have enacted the FIF law, and of those, where is it operational? For those that have FIF law, does the ratio of what facilities retain vary from one county to another? What are the benefits or impact in terms of financial autonomy for health facilities and in terms of service delivery? Then there's a question from Samuel Murage. He asked, the shift is to take over everything from the current NHIF. What about a prepayment? Example, the monthly contribution for the next 12 months in advance to cushion hospitalization. So Dr. Joy, you can go first, and then Dr. Gapsh can do next.
Thank you very much, Fiona, and thank you very much to my colleague, Dr. Masikela. I don't downplay curative services. Curative services are essential. They are not to be underlooked as we implement primary health care. And when you look at the multidisciplinary team will not only involve health workers, it will also involve others from other departments, water, agriculture, social services, gender, sports, in order to encompass all aspects of health which are just not curative, but also preventive and promotive. We look at the opportunities for curative if we decongest curative. If we do decongest curative, we are a country that can go into robotics, can go into other more highly specialized services in terms of the services that we deliver within our level 4, 5s, and 6s, and ensure that we are also training and capacity building it within these facilities. So we are trying to decongest, we are trying to reduce the workload of simple headaches, simple cases that can be handled at the lower level, and ensuring that now the curative services and the secondary care can handle more specialized care. Then in terms of the counties, the FIF laws, let me speak of what I know. And what I know is Nakuru County. For Nakuru County, the county never moved out of facility improvement funding during devolution as we went into the devolved government in 2014. And what was done was a regulation was derived from the Public Finance Management Act and developed a regulation for Nakuru County in terms of public finance management, a regulation of 2014. And that has been in place and has ensured complete autonomy of the facilities, ensuring that the budget, there is a structure for waiver and write-offs, there is a structure for the management of the facilities in terms of the boards, the committees, and the NHIF claiming strategies, the banking strategies, and ensuring the accountability frameworks were set aside from that regulation, which is drawn from Section 109 of the Public Finance Act. So in terms of other counties, I know there are counties which have drafted, which had drafted FIF Acts, but had not enacted them, had not operationalized them, but there are other counties which are working on ensuring that the current Finance Act is implemented. We are also working on that as the regulations are also being set out. So yes, some counties have, some counties have not. Different counties have different mechanisms. There was another question on So I'm not very conversant with what chief is taking over. And these are things we are all waiting for guidelines in terms of the way forward. We know we are owed largely by NHIF. We also are seeking guidance in terms of how we go about getting our reimbursements done, because the facilities are also overwhelmed. And we know by the next quarter, as we close the financial year, we really need to account for the NHIF reimbursements as we move forward. So back to you, Fiona. I hope that answers most of those questions.
Thank you, Dr. Joy. Maybe we can go to Dr.
Okay, thank you. I'll start with the FIF. Just to add on what Joya said, actually the FIF idea, the Facility Improvement Fund, had been there before devolution, where the facilities had to collect funds and actually improve the functionality within those facilities. But then with the devolution, there was a clear-cut lack of priority to our facilities as expected, and therefore a lot of funds that were collected from the facilities were being diverted to other different activities that are essentially not healthcare. And that's why there was a lot of out of stocks in those particular hospitals and understaffing. But I must say that, like, for example, Nakuru County in 2014, during the previous government, through the Act of the County Assembly, provided these facility, these ring fencing of funds to the facility. If the funds were for a particular collector in a facility, then they will be there. And you could see up to last year, the county that has the highest on-resource revenue was actually Nakuru County. So essentially, this now FIF Act that has been put nationally is just to make all other counties to have a standardized mechanisms to ensure that the money collected within those particular facilities are reinvested within the facilities. But our concern has been the same, the same way Ms. Clark has elaborated, that it is almost an impossibility to generate funds in a facility that are not functional, that are dysfunctional, that are not equipped with the mixed skill of personnel, that have the drugs, that people are going in to actually offer the services. And again, they are not empowered with the claim management system, because that has been in existence, whereby you realize that a particular facility offers services more than a public facility offers services more than a private facility. But a private facility has all the mechanisms and deliberate plan to claim these funds, while the public facility does not claim. So you realize that a lot of funds are being paid to the private facilities more than the public facility. And that explains why even in HIF, almost 80% of the services are being provided in the public sector, or 20% in the private sector, but the funds on the other side, 80% was going to the private sector. And again, we can also see, based on the claims that are being managed between, let's say, Nairobi Hospital and the Kenyatta National Hospital. For example, Linda Mama, you see KNH claim for last year was like 1.2 billion. That means that they had the systems put in place for ensuring that there is a costing to all those services. So I think that will enhance improvement of facilities if those facilities are functional. Thank you.
Okay, thank you so much. So I see no other question. So I see no other questions. So before, in case I don't lock anyone out before my vote of thanks, so I guess we can move to the conclusion part of the webinar. We're grateful for the webinar, and so on behalf of the Institute of Economic Affairs, I extend my heartfelt thanks to everyone who has been able to contribute to the success of this event. First, I would like to express our deepest appreciation to our speakers, Dr. Joy Mugambi and Dr. Dabchi. Your expertise have really enlightened us in terms of healthcare financing, in terms of the healthcare infrastructure. So thank you so much for sharing your knowledge with us. I also want to thank our participants for your questions, for just giving us your time to be here and also just actively involved in terms of the conversation that we've had today. Also, thank you for our IT team and the communication team for having planned this and also just ensuring a smooth webinar from our side. So thank you so much. Let's all carry this knowledge, have conversations with people at home, people in our workplaces, and we look forward to having future engagements and continued collaboration.